All right, if you're on your OB rotation or staring down step 2 prep, you are in exactly the right place. We're going to do a high-yield breakdown of prenatal screening for chromosomal abnormalities. No fluff, just the stuff you absolutely have to know for your exams and, more importantly, for the wards. Let's dive in.
So here's the game plan. First, we'll hit the why, which aneuploidies we're actually looking for. Then, we're going to hammer home the critical difference between screening and diagnostic tests. It's a huge point. After that, we'll walk through the timeline, first and second trimesters, and wrap up with how we actually confirm a diagnosis. It's a super clear roadmap, so let's get going.
Okay, first things first. Why do we even do all this screening? Well, you'll see this every day in prenatal care, and it all comes down to one word: prevalence. We screen for a specific group of conditions because they are, statistically, the most common and clinically significant ones you're going to encounter. Let's take a look at the actual numbers.
Okay, let's kick things off with the big one, the one everyone knows, trisomy 21, or Down syndrome. It's the most common autosomal aneuploidy we see in live-born babies, showing up in about 1 in 700 births. This number, right here, is really the anchor for why we offer this kind of screening to every pregnant person.
So what about the sex chromosomes? Well, the most common one you'll come across is 47XXY. That's Klinefelter syndrome. And get this, it occurs in about 1 in 500 males. So yeah, within that specific group, it's actually more common than Down syndrome. That's a great little fact to keep in your back pocket.
This table really gives you the whole picture. So you've got trisomy 21, and then you see trisomies 18 and 13. They're less common for sure, but they're typically much more severe clinically. And on the sex chromosome side, we've got Klinefelter and then Turner syndrome, 45X, which, by the way, is the only monosomy that's compatible with life. Remember that one. So these 5 conditions right here, this is the core panel we're screening for.
Okay, I need you to lean in for this next part because this is absolutely crucial. I'm not just talking about your exams, I'm talking about counseling real patients on the wards. If you only remember one thing from this entire explainer, please make it the difference between a screening test and a diagnostic test. They are not the same thing, and mixing them up is a huge pitfall.
So here it is, the key distinction. Screening tests are non-invasive. We offer them to everybody, but they do not give you a diagnosis. They can't. All they do is assess risk. They tell you, hey, this patient is high risk, or this patient is low risk. That's it. A diagnostic test, on the other hand, is invasive. It's what you do after you get a high-risk screening result to get a definite black and white yes or no answer. Screening is all about probability. Diagnosis is all about certainty.
All right, let's put this into a real-world context. We're going to walk through the pregnancy timeline,